in the 1980s with Graham Hughes, who had significant reservations about the NIH regimen of monthly cyclophosphamide given for 6 months followed by quarterly for 2 years, which is a very toxic regimen. No question it's effective, but there's a significant risk of viral infections and ovarian failure. And we've shown in prospective studies, this is just one slide from Frederick Cusio, who's led this study with us, that this is a control study comparing the St. Thomas's lupus cyclophosphamide regimen, which I'll show you in a minute. It's actually a fixed dose of 500 milligrams of cyclophosphamide given every 2 weeks, 3 months, followed by azathioprine. And the comparison was with the standard NIH regimen, followed by azathioprine. You can see there's no difference here in terms of progression to end-stage renal failure. So, how do we treat severe disease? This is the Euro-lupus regimen, renal and extrarenal manifestations, and certainly one indication for using cyclophosphamide is patients who just don't take their drugs. So, at least by giving an intravenous infusion, you're sure that they're getting treatment. So this is our protocol. Abdominal biopsy, we will give them intravenous methylprednisolone, 500 milligrams, followed by this regimen, 500 milligrams as a fixed dose every 2 weeks for 3 months, and then we'll follow it with azathioprine. As I've showed you the slides, this is a very effective treatment for lupus nephritis. Having said that, mycophenolate is now standard of care. This is the trial design of the ARM study, Esprit de lupus management study. The first part of the study was a 6-month induction treatment, mycophenolate 3 grams a day versus the NIH cyclophosphamide regimen. And you'll know there's plenty of data. Ellen Ginsler and Daniel Chan, T.M. Chan have all shown that this is a good way to treat. Well, these studies suggested actually previously that mycophenolate was superior. The data from our study suggests that this is equivalent. There was no superiority of mycophenolate over NIH cyclophosphamide. The design of the study then was that responders, and only responders to this induction regimen, went on to the maintenance therapy. And in the maintenance arm, the data's not published yet, but we know that mycophenolate is superior at maintaining remission compared to azathioprine. So this is our strategy now as standard of care. We've put together some guidelines, and this is now the standard of care, particularly applying to non-Caucasian patients, especially if there are fertility issues. So renal biopsy, methylprednisolone, followed by mycophenolate. We just started and we keep going. So I think this concept of induction versus maintenance is rather fading now with mycophenolate. What do you do if they flare? So we've started this as our standard regimen now, mycophenolate. If they have a renal flare, our policy usually is to rebiopsy them, mainly to make sure that nothing else has happened, like APS nephropathy or whether they've changed their class of nephritis. And if they've flared and we're sure that the patient's taking their medication, then we will probably switch them to the Euro-lupus cyclophosphamide regimen. And then go back to mycophenolate or azathioprine after that. What do you do if that fails? Well, you're into the realms of biologic agents, clinical trials, mainly it's up to you actually, but it is a difficult area in chronic relapses of renal disease. So mycophenolate is becoming standard of care for the treatment of lupus nephritis. It's particularly useful in women of African ancestry. There's trial data to support that these patients do respond better to mycophenolate than cyclophosphamide. Certainly if a young woman is planning pregnancy in the future, this will probably be the first choice as opposed to cyclophosphamide. Having said that, our experience with low-dose cyclophosphamide is very good. We've had virtually no women who've been rendered sterile with our low-dose cyclophosphamide regimen, so it's not a problem from our point of view. But we tend to still use the cyclophosphamide regimen in patients with severe renal and extrarenal disease and patients who are non-compliant. So that leads on to this strategy for prevention of end-stage renal disease. Many studies have shown that the single most common cause for progression to end-stage renal failure is the patient not taking their drug or not turning up to clinic. So patient education is really critical here. Careful follow-up, rigorous blood pressure control, which we've learned from the nephrologist, control of proteinuria with ACE inhibitors or ARBs, angiotensin receptor blockers. Pay attention to thrombosis risk. APS nephropathy, I described in detail earlier on. Patients who are severely nephrotic are by themselves increased risk of venous thrombosis. Pay attention to glucocorticoid